Chapter 20, Principal Techniques of Disinfection. Disinfection processes. During patient treatment, surfaces and equipment in treatment rooms are likely to become contaminated with saliva or by aerosol containing blood, saliva, or both. Laboratory studies have shown that microorganisms may survive on environmental surfaces for varying periods. Assume that if a surface has already contacted with blood, saliva, or other potentially infectious materials, it contains living live microorganisms. The CDC Guidelines for Infection Control in Dental Healthcare Settings 2003 divides environmental surfaces into clinical contact surfaces and housekeeping surfaces. Clinical contact surfaces can be directly contaminated. Housekeeping surfaces include floors, walls, and sinks with much lower risk of disease transmission. Cleaning and disinfecting considerations. Clinical contact surfaces. The amount of direct patient contact, the type of frequency and hand contact, the potential amount of contamination by aerosol and spray, and other sources of microorganisms. Clinical contact surfaces. Current infection control guidelines of Office Safety and Sepsis Procedures Research Foundation, OSAP, recommend that clinical surfaces be classified and maintained under 3 categories: touch, directly contaminated, transfer in contact with contaminated items, splash, spatter, and droplet housekeeping surfaces, no direct contact. Surface contamination. There are 2 methods of dealing with surface contamination: surface barriers and pre-cleaning and disinfecting surfaces between patients. Surface barriers. A wide variety of surface barriers are available today and should be resistant to fluid and keep microorganisms in saliva, blood, and other liquids from soaking through the surface and underneath. Some plastic bags are designed for the shape of items such as the dental chair, air water syringe, hoses, pens, and light handles. Plastic barrier tape is frequently used to protect smooth surfaces. Single-use or disposable items, used only in one patient and then discarded, so they help reduce the chance of patient-to-patient contamination. Single-use items are often made of plastic or less expensive materials. They are not intended to withstand cleaning, disinfection, or sterilization. Never process, clean, disinfect, or sterilize single-use items for use on another patient. Although no cause of cross-contamination has been linked to dental treatment room surfaces, cleaning and disinfection of these surfaces are important components of an effective infection control program. In addition, the OSHA bloodborne pathogen standard requires that contaminated work surfaces be disinfected between patient visits. Pre-cleaning means to clean before disinfected. All contaminated surfaces must be pre-cleaned before they can be disinfected. Even if there's no visible blood on a surface, it must be pre-cleaned because even a thin layer of saliva on the surface can decrease the effectiveness of disinfectant. Pre-cleaning reduces the number of microbes and removes blood and saliva, also called bioburden. Disinfection is intended to kill disease-producing microorganisms that remain on the surface after pre-cleaning. Spores are not killed during disinfection procedures. Do not confuse disinfection with sterilization. Sterilization is the process in which all forms of life are destroyed. Disinfectants. Chemicals that are applied to inanimate surfaces, chemicals that destroy or inactivate most species of pathogenic microorganisms. Antiseptics are antimicrobial agents that apply to living tissue. Disinfectants and antiseptics should never be used interchangeably because tissue toxicity and damage to equipment can result. In dentistry, only those products that are EPA-registered hospital disinfectants with tuberculocidal claims should be used to disinfect dental treatment areas. Tuberculosis is a highly resistant to disinfectant, and if a disinfectant will inactivate tuberculosis, it'll inactivate less resistant microbial families. The ideal surface disinfectant would rapidly kill a broad spectrum of bacteria, have residual activity and minimal toxicity, not damage the surface to be treated, be odorless and inexpensive, work on surfaces with remaining bioburden, and be simple to use. No single disinfectant product on the market today meets all of this criteria. When selecting a surface disinfectant, you must carefully consider the advantages and disadvantages. Follow manufacturer's recommendations for mixing and diluting, application technique, shelf life, activated life use, and all safety warnings. EPA registered intermediate level hospital disinfectant with tuberculocidal action. Because identifiers can contain iodine, they may corrode or discolor certain metals and may temporarily cause reddish or yellow stains on clothing and surfaces. Synthetic phenol compounds, EPA registered intermediate level hospital disinfectant with broad spectrum disinfectant actions. Phenols can be used on metal, glass, rubber, or plastic, and may be used as a holding solution for instruments. Sodium hypochlorite, household bleach, is a fast-acting, economical, and broad-spectrum intermediate-level disinfectant. It's unstable and must be prepared daily, has a strong odor, and is corrosive to some metals. Not recommended product for dental setting. Alcohol are not effective in the presence of blood and saliva. Evaporate quickly and are damaging to certain materials such as plastics and vinyl. Not recommended as a surface disinfectant. Immersion disinfectants. Some chemicals on the market can be used for sterilization or high-level disinfection. When used as sterilants, they destroy all microbial life, including bacterial endospores. A weaker dilution with shorter contact time. These chemicals provide high-level disinfection, inactivating all microorganisms except endospores. Most of these chemicals are toxic and can irritate the eye, skin, and lung. PPE must be worn when these chemicals are used. High volume evacuation reduces the risk of saliva escaping from the patient's mouths. Regular cleanings help tubes and pipes flow easier. Clean by flushing with detergent or water. Periodically clean the traps. No scientific evidence showing housekeeping surfaces pose a risk for disease transmission in the dental healthcare setting. Majority of housekeeping surfaces need to be cleaned only with detergent and water or an EPA-registered hospital disinfectant and detergent. Make fresh cleaning solution each day and discard any remaining solution, and let the container dry to minimize bacterial contamination. Carpeting is more difficult to clean than a non-porous hard surface floor. It can be reliably disinfected, especially after contamination with blood and other blood substances. Studies have documented the presence of bacteria and fungi in carpeting. Cloth furnishings pose similar contamination risk in an area where direct patient care is performed. No scientific evidence shows that HIV, HBV, or HCV has been transmitted from a housekeeping surface. OSHA requires that blood spills and other body fluids be removed and surfaces disinfected. Clean spills of blood or other potentially infectious material and decontaminate the surface with an EPA-registered hospital disinfectant with low level to intermediate activity, depending on the size of spill. Protecting the environment has become an important part of our personal lives and in our homes. Many of the infection control products and procedures we must use to protect our patients and otherwise have a negative impact on the environment. By alternating a process or material that is possible to minimize a potential negative impact on the environment. For example, using disinfectant wipes instead of spraying disinfectants could reduce the amount of chemicals in the air. Paper, digital patient records have a significant impact on the amount of paper that's used. Digital radiology is rapidly becoming state of the art. Protective barriers present a challenge in the attempt to go greener, but some are recyclable. And surface barriers involves the use of chemicals in PPE.